In this video we are going to discuss the method of repetitive nerve stimulation for the diagnosis of disturbances in the neuromuscular junction. There are many methods for the diagnosis of myasthenia, the most important being the clinical with history and fatigue testing, but we have also some other tests. Repetitive nerve stimulation, which is the topic of this video. We have the single fiber EMG. We have other special more rarely used techniques, and we have the antibodies against the receptor. Here is a picture made by Decrement long ago to show the post-activation cycle in the neuromuscular junction. Here is a period of voluntary or electrical activity. Directly after that, we see an facilitation due to an increased release of acetylcholine that will improve the neuromuscular junction. That is relatively short-lived. And then during the activation we have an exhaustion of the stores of acetylcholine, and therefore we end up with a depression of the transmission that is recovering very slowly. And what we see in the decrement testing is the combination of these two curves, the facilitation and the exhaustion, giving us an initial facilitation and then a period of problematic transmission and then a recovery. This is schematic drawing of end plate potentials, which are generated in the end plate when we have stimulated the nerve, and then we have the end plate, and when it reaches the threshold for firing, an action potential is fired. But here I've suppressed that. That also can be done experimentally, and we see the full extension of the end plate potential. And these are three stimuli, and you see how the amplitude decreases also in the normal muscle. So we have a decrement already there, but that is not seen in the practical situation, since the end plate potential are way above the threshold, and that is called the safety factor. But if the safety factor is reduced due to a transmission problem, then maybe the first end plate potential gives rise to an action potential, and the second also barely, but not the third stimulus. And here is what we see when we make the drawing of the action potentials instead. These are all or none phenomena. Either they are there or not. And here is what we see in the myasthenic example, where the first stimulus gave a response, the second one with variable delay here, and the third one does not give a response. And this is the basis for the decrementing response. Here are responses from individual motor end plates in the muscle. This end plate could only respond once, and this one 3 times, this one 5 times, and so on. And when we add the activity from all these, we see on the surface of the muscle a large CMAP in the beginning, and then a decrease because of fatiguing motor end plates, and then it stays low. But towards the end we have a kind of improvement that is an internal facilitation that we also see for the individual end plates. This is called the saddle shape, and what we measure is the change in amplitude and area between the first and the fourth, or first and the fifth. Amplitude and area are equally good. And here is the protocol that was suggested based on what I just said, namely that we do a repetitive nerve stimulation with 3 Hz and make a short period of activation, 10 seconds, to see facilitation, particularly important when it comes to Lambert Eaton diagnosis, Lambert Eaton myasthenia diagnosis. The amplitude is increased compared to the initial amplitude, and also the decrement is less pronounced. But the more important part of the protocol is when we have a long-term activation, more than 30 seconds, for example 60 seconds. And here we have the initial decrement at rest, and then activation, and then we see maybe a lower amplitude because we miss the facilitation here. So we have a lower amplitude and more pronounced decrement. Most pronounced after a minute or so, and then recovery after 3 minutes. In the Lambert Eaton myasthenia, we have very low initial amplitude, a short period of activation, and then a pronounced facilitation. We see the decrement also here. So what we measure is then the amplitude and the decrement before and after activation. The facilitation is an interesting phenomenon. Here in the normal muscle, we may see a facilitation or an increase in amplitude up to 20%. Usually it's much less. And this is partly a technical artifact and partly ionic changes in the muscle fiber rather than in the neuromuscular junction. In Lambert Eaton myasthenia, the increase in amplitude can be more than 100%, many 100%. And in myasthenia gravis, it can amount to 60%. So the cutoff limit between facilitation in myasthenia and in myasthenic syndrome is 60%, according to tests that have been made by Sanders and his collaborators. Here we have some comments on the two parts of the protocol. The 3 Hertz immobilize the muscle, maximum stimulation, strength. Why 3 Hertz? Well, if we do the test with 1 Hertz, we may not get the decrement at all, and if we use 10 Hertz, then we get the facilitation that will hide a possible decrement. So 3 Hertz is somewhere in between and generally accepted as a good frequency. And why 10 stimuli and not only 4? Well, we want to see the typical saddle shape. It is not seen in every case, but almost. But we have other conditions that give a decrement without the saddle shape. It's just a continuous decrease in amplitude. And that is a red flag to look at other reasons for the problem in the transmission. And why do we need to immobilize the muscle? Well, that is because the shortening of the muscle will lead to an increase in amplitude, so it looks like a facilitation. So we try to immobilize the muscle as much as it is possible. Not all muscles can be immobilized. And why max stim? If we have a just borderline stimulation strength, and we have small movements during repetitive stimulation or during the voluntary contraction, then we may come out of position and we get something that looks like a decrement. So make sure that we have a stimulation strength that is 125% above the liminal. So what we see with this short-term protocol is the post-exercise facilitation, the number of motor templates that are physiologically there and can be activated by increase of acetylcholine. The 10-second activation is tested and by Shin-Oh and his colleagues, and they found in Lambert Eaton myasthenia that 5 seconds or 10 seconds gives the maximum degree of facilitation. Then you start to have some exhaustion. So 20-second facilitation activation is not as good as 5 to 10 seconds. Then we have the long-term protocol that gives the post-exercise exhaustion, and that is more related to the myasthenic fatigue, and that is also more often positive in terms of giving a diagnosis of myasthenia than just rest or shorter degree of activation. And what we measure, as I said, is the initial amplitude and the decrement after activation. And our parameters tell us different stories. The initial amplitude is number of surviving motor templates. The decrement is the safety factor, and the facilitation is how many motor templates that still can respond to increase in amplitude after internal increase in acetylcholine or by drugs. And the exhaustion of the long-term activity is related to the myasthenic fatigue, and then we have combined feature that I may allude to later. We have some methodological considerations here. As we know, clinically, the proximal muscles are usually more involved than distal, and the proximal muscles that we test is deltoid, trapezius, anconeus, sometimes nasalis. Deltoid is the most sensitive, but it's also painful and technically more difficult. So trapezius is safer and still diagnostically good. For bulbar myasthenia, we use the same muscles. Nasalis is always a little difficult for good recording quality. And ocular myasthenia, their repetitive nerve stimulation does usually not add so much. Here we have a comparison of decrement within the same patient for deltoid and trapezius, and you see here how the decrement in deltoid was 50% and in trapezius 25%. Here it was 32% and 12% and so on. It's nearly always deltoid that has a larger decrement than the trapezius, but exceptions are also seen. And here is similar plot comparing the abductor digiti minimi and the higher decrement, the more pronounced decrement in deltoid and little less in anconeus. Rest and fatigue, if the patient is exhausted when coming to the EMG chair after having climbed a lot of stairs, for example, then we get the diagnostic advantage of that, but it is difficult to compare exactly the outcome at different repeated examinations with each time the patient is coming in. So there we recommend, if you want to make follow-up in detailed way, to have the patient resting for 15 minutes before you start the test. On-off treatment, that is particularly for the cholinesterase inhibitors, that we put the patient off treatment if possible for 12 hours before testing. And temperature is very important, and that can be shown in the following way. Here is the normal situation, and here's the myasthenic situation. In the normal, we have this decrement I already showed you, and with cooling the end plate potential amplitude is increased. And with warming, then it is little less, but still it's not critical because we are still way above the threshold. So we, in the normal muscle, we don't see any effect of cooling and warming. But if we have critical situation, then in myasthenia, to start with, we are here, and if we have cooling, we have a better end plate potential that now all of them will reach the threshold and get clinically improvement, and we do not see decrement. But if we have warming, then the end plate potentials become smaller, and we have clinical symptoms, more severe myasthenia, and we have more decrement. And stimulation in muscle fixation, deltoid, we can press the elbow a little mechanically with our own hand, and trapezius, patient can hold the seat of the chair and pull in this way, stabilize the trapezius. And for the hand muscles, we simply place a small strap around the fingers to avoid too much movements. Here are typical examples of signals. This is deltoid with a slow rising phase and a plateau, and this is the abductor digitive. Abductor pollicis brevis. This is trapezius. It should be a relatively sharp peak. If they are prolonged here, then we are probably misplaced the recording electrode and recording from, for example, longissimus dorsi. And here is from the nasalis muscle. These are recordings from the anconeus muscle. What about normal reference limits? Well, some laboratories use 10%, others higher. There is actually no decrement in the normal muscle at all, but we must allow something for technical reasons. And we have looked at some patients that did not have myasthenia but were referred for that to our laboratory, and we found that in the abductor digiti minimi we found 3.4%, anconeus 4%, deltoid 5%, nasalis 5%, trapezius 4%. So we have set the limit to 5%. It is the 5% confidence limits, and the decrement should not exceed 5%. I think it's important to try to get really good quality, and then the sensitivity of the technique is improved. What do we get out of the study? Well, first of all, is it a myasthenic shape of the decrementing response, or Lambert Eaton shape, or not at all? The possible effect of cholinesterase inhibitors can probably be seen by the amount of facilitation. We can see cholinergic overdose in as extra discharges after the CMAP. That is also seen in congenital myasthenia of different kinds. This can be seen as multiple waves in different nerves here. And here it is an excessive amount of activity after the CMAP. Normally it should be silent here, and this is signals that are generated distally, and they disappear immediately when we do a 3 Hz stimulation. Already after the second pulse, the others here disappear. Is it presynaptic or not? Here is a situation with the Lambert Eaton myasthenia, 1 millivolt amplitude here, and here is 6 millivolt after activation. This happens to be 20 seconds, and you see the dramatic increase in amplitude. That can also be seen with stimulation for a couple of seconds. This is 20 Hertz and this is 50 Hertz, but the outcome is not very much better than the voluntary, which is non-painful, so we prefer to use this one. But sometimes, for example, in the intensive care unit, we may need to use electric stimulation. Here's a patient that we followed over many years with repeated studies of the CMAP amplitude after only one stimulus. Here is the first stimulus, and this is after voluntary activation for 10 seconds. And you see how the amplitude here in the beginning of the time when we saw the patient has increased quite considerably, and there is a therapeutic gap here between what we see here before and after stimulation. Here, for example, we have this amplitude at rest and this amplitude at activation. So little more drugs can probably help to fill in this gap. And here's another plot of the same thing where we can follow the patient and the amount of treatment. Here he was obviously over-treated, so then the activation gave a deterioration of the CMAP. In congenital myasthenia, we may have other findings. If we have a presynaptic condition, maybe we don't see any decrement at all with just 10 stimuli, but by exhausting the stores of acetylcholine with hundreds of stimuli, we can see how the amplitude continuously decreases, and we get this effect not seen in a normal motor end plate or in ordinary myasthenia gravis. And we have also other conditions. Here is a patient with weakness, and the question was whether it was hysterical or not. And we made a CMAP and again a CMAP at rest, and then had patient to activate the muscle for 3 minutes, and immediately after that we got amplitudes that are very much smaller than at rest, and this was the pattern of a hypokalamic periodic paralysis. What about the sensitivity of repetitive nerve stimulation? Well, in ocular myasthenia, we nearly have no reason to do the rep stim. It is really very insensitive. In mild generalized, we see hand muscles and deltoid. First of all, 70% is pretty good, and you see the difference between distal and proximal muscle here. And in more severe situations, the sensitivity can go up to 90% with proximal muscle. Single fiber is blocked here. You see higher numbers, but we do not discuss that here. We have pitfalls. Maybe we miss decrement sometimes. Maybe we get artificial decrement in other situations. So why don't we see a decrement in a patient that seems to have myasthenia? Well, we may have tested the wrong muscle. We have tested the hand muscle instead of trapezius. why don't we see a decrement in this patient that obviously has myasthenia? Well, maybe the muscle was cold, and that is particularly true for the hand muscles. Proximal muscles, there it's easier to avoid cooling because these muscles are normally warm. And then, why do we get so much decrement here in this patient that still does not have myasthenia? Well, this stimulating electrode, recording for that matter also, but the stimulating electrode may be out of position, maybe it is a subliminal stimulation, and we have small movements during repetitive stimulation and during voluntary activation that get the stimulating electrode out of place, that gives something that looks like a decrementing response. Or we have made erroneous interpretations. We have not seen the details of the decrement in the right way. So be careful. It looks simple, but it can give quite a lot of information, but it has to be technically perfect. To summarize, it is quite a good technique for diagnosis of myasthenia, not for excluding myasthenia, but for confirming. It is available in all EMG laboratories, I suppose. But a decrement is not equal to myasthenia or equal to Lambert Eaton myasthenia. It is only a sign of disturbed neuromuscular transmission, and that can happen in other conditions as well, particularly in reinnervation, where we initially, after nerve damage or a chronic situation for that matter, have disturbed neuromuscular transmission in immature motor end plates, giving decrement. In ALS we can have up to 20% decrement. And repetitive nerve stimulation can also be abnormal in channelopathies. So thank you very much, and here is a saddle shape.